Welcome to episode 156, Prioritizing Reflection, the Value of Clinical Supervision for the Addiction Workforce, featuring Samson Teklemariam, licensed professional counselor. Make sure to subscribe to be alerted about future episodes. By Clearly Clinical, learn, grow, shine. Hello to our listeners. My name is Elizabeth Irias, and I am delighted today to be joined by my colleague, Samson Teklemariam. He is a licensed professional counselor and also the Vice President of Clinical Services for Behavioral Health Group. And today he is joining us in a conversation about the importance of supervision in the treatment space. And this is a topic that is very close to my heart because I worked in treatment for a number of years. And I know it's close to Samson's heart as well. So thank you for joining us, Samson, and also thank you for our listeners tuning in on this topic. So Samson, why don't you tell our listeners a bit more about you and how you came to have this specialization?
Yeah, thanks, Beth. I mean, the best answer I can give is I would not be where I am in my career without clinical supervisors. There's no way. I do know a bunch of people who have made it in spite of clinical supervision. So, that's kind of like the two sides of the coin. Like some things in life you get passionate about because someone didn't do it well. And you're like, I'm determined, to fix this or do it better. And some things in life you're there really because folks, laid the path, in front of you. And I would say I'm part of the latter. Is I really had some incredible supervisors. I will definitely shout them out, throughout this time together.
Ditto. I am smiling and nodding as you say that because I could not have learned almost anything had it not been for good clinical supervision. So I don't even know where to start because this is such a big topic. From your perspective, you have a very forest through the trees view on this because you are high up in the organizational hierarchy to see how all of these pieces fit together. From your perspective, looking at treatment as a whole, particularly substance abuse treatment facilities, what do you see that happens organizationally that causes a breakdown of clinical supervision?
Yeah, I mean, this is going to be the easiest answer, and it's so hard to accept this as counselors, but money is a driver, and unfortunately we have so many other things in our work that are reimbursable, and what's not reimbursable sometimes is our learning, our growth, our professional development, and even how we are monitoring the quality care of our patients, clinical supervision. And so what's the first to go when we're overburdened, when we have more patients than staff? Sometimes what's first to go is clinical supervision. It's a cut corner, so I think that's why it's the biggest issue, is because it lacks consistency in a lot of our programs. And when we do see clinical supervision, uptick in terms of consistency, we see all the other data points and key performance indicators rise. So we see patient satisfaction rise. We see patient safety, patient engagement, patient retention, showing up, for appointments. We see all these other really important, treatment areas get better when clinical supervision is more consistent. And yet we cut that corner, pretty often. And so that I think that's kind of the shortest answer. I mean, the dream is I wish it was reimbursable. There's a couple of states who have piloted it, and there's a couple of grants that support it, depending on what state you're in. And so there's an opportunity there, but we should all kind of function under the expectation that if it is not a reimbursable hour, how do we still make it a priority, and make it a key stake of what we do and how we do it.
You bring up a really good point, which is the impact of the dollar. And coming from my background working with Los Angeles County Department of Mental Health, you end up with so many different grants, so many needs and hats that program directors are trying to wear. And historically, and I'm sure you'll probably agree, when we look at public funding-based programs, there is such a heavy price to pay with any minute, hour you spend. Like, what is the consequence for "quote unquote" productivity? And that if supervision is not considered part of that productivity, it's so easy to get put on the chopping block.
Right. Yeah. And with so many, when you think about it, with so many counselors coming into the field with limited experience, a lot of their understanding the workforce comes from the workforce. A K-CREP university doesn't teach you how to write a progress note, unfortunately, right? And they also, in addiction treatment specifically, only require one elective hour on addiction. So an LPC, an LCSW, LMSW, LMFTI, any of these credentials can come into the field with literally 0 hours of education on addiction treatment, other than differential diagnosis, maybe how to run a group, but not on the fundamentals of how to document the services we deliver, right? How to track them, how to do chart auditing. They may have never even heard the phrase chart auditing before, and yet it's a fundamental part of their day to day, when they get into the field. So, how do they learn this? I mean, yeah, we have some formal trainings that sometimes we provide. You may have an LMS, a learning management system, but the truth is that all those training modules almost don't do anything if you don't have a mentor, if you don't have a true clinical supervisor to give you feedback, coaching, and just kind of keep nudging you in the direction of compliance, adherence, or really just how to function in the field.
So, in the conversation about clinical supervision, we generally put that in the heading of something that's required and only necessary for folks who are pre-licensed. So, for the interns, associates, whatever particular language your state uses. Do you see in the addiction space that when you're working with a licensed team, clinical supervision just goes by the wayside because you have the quote unquote independent judgment that the state licensing board has given you? So it's very easy at that point to just get rid of clinical supervision altogether because you're no longer required to do it in order to keep interns.
Yeah, that's a great question. It's like really what you're asking is what's our motivator, Because if the motivator is, okay, it's mandated because this is a limited permit, someone with an I or an A at the end of their credential, that in and of itself is you're essentially adhering to the lowest bar of expectations, So you're not even trying to elevate beyond that low bar and saying, okay, what's the best practice? Why is that a requirement? It's not just a requirement for education and experience purposes. It's also a requirement so that we're not lone rangers, in a really, really sometimes dark space. If you're seeing 20 patients, I guarantee you one of those patients is going to challenge something personal to you. No matter how seasoned you are in this field, you cannot protect that personal attack, kind of on you. You can't do that all by yourself. It doesn't even make sense. In fact, if you do so, you're sort of going against the grain of what you're coaching and teaching your patients, aren't you? You're sort of encouraging them to always get help. I really love these BetterHelp commercials. I'm glad they're spending money on it. Like, hopefully it'll help us get help. But there's some hilarious, BetterHelp.com commercials out there, and some of them are like, someone who's floating out there in the ocean, and people are trying to toss them like a life preserver. Come on, we'll help you. No, I got it. I won't drown. And so you always see these moments of someone just kind of trying to handle a lot of pressure or weight on their own. And I would almost argue that the longer you are in this field, the more clinical supervision you need. Not more in terms of frequency, but more in terms of consistency. You may not need to report to the state 4 hours a week or 2 hours a week. Like, it may not be that exact frequency, but you do need that check-in. You do need that partner or colleague or senior member of the profession to connect with you and check in with you on your cases, how you're managing them, and whether or not they're managing you, And I think that actually becomes a bigger need over time as we get, maybe sometimes edged, in this field and get bitter to some things we've experienced.
I'm glad you bring up that element because I think it kind of crashes into the burnout associated with a particular workplace and with a particular culture, and then also the possibility for the development of compassion fatigue, and that clinical supervision can be a way to monitor and correct that. And that's what the research has shown. But I think it is really easy for us to trim that away administratively. So what happens? What happens when we don't have adequate supervision? Why don't you tell us some horror stories?
Yeah. I mean, I won't call out names, but here's something funny. Beth and I chatted a little bit before and just realized how many connections in our field we had. We both worked for a past agency at the same time and didn't even know it, because it was national. And I'll tell you something that I learned from that agency was just the power of clinical supervision when it comes to maintaining boundaries. When we started looking at reports of ethical violations, in a national company at a national level, it was never like an employee who's always skipped their trainings that ended up in a boundary issue. It was almost always an employee who may have not had any level of accountability. So think about this. Think about boundaries. Think about someone who crosses a boundary. Is it Cinemax? Is it like, hey, my name's Joe. Hey, my name's Jane. We're in bed together. Like what? No, I mean, it's not like that's not a thing, right? Normally what happens is you've worked with a patient for months. They've noticed little details about you. They've noticed that you have a picture of a family member. They may have talked about how they had a relapse because someone close to them passed, and you may have self-disclosed, oh, I just lost someone recently. All of a sudden you show up in a session 90 days in with this patient, and you sit down and you say to them, hey, how was your week? And they say to you, well, I mean, how about you? How are you doing? Didn't you lose someone a month ago? And so now that intimacy gets flipped a little, and they pull, more and more pieces, right? And let's say that the people who are close to you aren't checking in with you. Let's say that there's a void, that no one has asked you, how are you doing with that loss? I see you came back just 1 week after bereavement. Are you really ready? Are you settled? I see you've got a full caseload less than a month after bereavement time. Like, no one in terms of your colleague is checking in with you, but this one patient has enough, let's say, empathy, right? Or countertransference, or transference, but they have enough to ask, and they start checking in with you. Now they're filling a void. And now week to week, you both are sharing, right? Can you see how that can evolve without a supervisor present just to check in, just to give you some accountability, right? And so I think that's where we see it. We see a lot of these boundary violations occur in light of someone not having any accountability, not having anyone to promote their own self-awareness, right? How they're actually doing in the room with these patients. And so when we say, okay, how can we see it go wrong? That's how it goes wrong, is no one even checked in with this counselor, with this physician, with this nurse. And we see this in every single sector of helping, is that power differential changes, of them sharing and us listening, to them sharing and us sharing, to them being the only one who's checking in with us. Intimacy develops, trust develops, and it turns into something else,
You led with the boundary foot. Do you see that as being really the primary benefit of clinical supervision? Is it about boundaries? Is it about education? Like, how do you break that down when so for our listeners, Samson has worked in national organizations as various kinds of directors of training and professional development. So he has a very unique perspective on this. So is supervision really about boundaries, or how would you break it down of like, this is what we need to focus on in supervision?
Yeah, the reason it's so important is no, it's about so many other things, right? So I'll steal something, I guess, from Dr. Corey Hayes. We all know him as like one of the founding, one of these groups who helped find like core clinical competencies. Dr. Moulton and Murtori in clinical supervision in the helping professions. This is the second edition practical guide. They gave us 4 primary goals, and then they wrote a whole textbook, about a lot more. So one of them is, yes, protecting is what it's called. That's one of the main goals of clinical supervision, protecting the welfare of patients. But there were 3 other goals. One is promoting professional growth and development. We talked about all those credentials. A lot of those credentials come into the field as generalists. And there's nothing wrong with being a generalist, right? But can a general physician perform neurosurgery? I mean, hopefully not on their first day as a general physician, but sure, could they grow into a neurosurgeon? Yeah, definitely. They could build a specialization. They can start earning hours, start getting coaching, start getting clinical supervision. We desperately need specialists as our understanding of neuroscience, of the mind, of mental health, promoting well-being, as that evolves, we definitely need specialists. So I think one area they talked about was promoting professional growth and development, helping that new professional assess where their giftedness is, where their track is, and start building, in that direction, right? The one of the other goals that they listed was monitoring. So monitoring the performance of counselors. Who's doing your individualized development plan? Who's helping you track your goals? helping you grow towards your goals. You say you want to pick up a second credential, in addiction treatment, but do you even know what that is, what board it is? Are you going to the right board? Is it billable in our state? Is, someone to help you navigate that. You have no idea how many times counselors who didn't ask those questions, get those supervision points, picked up the wrong credential. They may have picked up a national credential, which is awesome. I love national credentials. I work for NADAC. I love them. Unless if you're in one of those states that's really nitpicky and requires you to have a state credential first. Well, now you just wasted a year and a half of your life and you've got to do it over again. And it's usually because you didn't have someone who's seasoned in the field to help you make that step. Right. And so there's a lot of small decisions we have to make as professionals. And yes, being monitored or receiving monitoring of our performance and our performance goals is really critical. Also helping us to curb edges in areas where we're not as sharp or not as strong. So some folks are really good, in terms of people person. So their patients love them. If you did a survey, a patient satisfaction survey, they may get 100%, right? But if you do a compliance check, you may see that, 18 out of 30 of their billable hours were actually received and not recouped. So they're almost at a 50, 60%. That's a failure. They're doing hours that are not counting, right? So that's not just about money. It's about, are you adhering to key stakeholders' expectations for how you're delivering your clinical services? Again, there's like that wild, wild west style, or that's, do we want to work in a pocket of evidence-based programs and practices? And so monitoring is really key for that, especially if we want to, include fidelity in our practice, right? A lot of folks say they're doing CBT. How do you know it's CBT? If no one's really monitoring or doing a fidelity check to see that it's honestly delivering what it says it's delivering, And then the fourth that they put in there was empowering. And I think the empowering counselors to both, heal and be well, in their own work, but also to supervise themselves one day and promote that autonomy, that empowering goal of clinical supervision that they listed in this textbook. It helps with that self-care kind of burnout prevention that you talked about. Some folks call it
compassion fatigue.
Yes, fatigue. Yeah, compassion fatigue. Here's the cool thing with fatigue. Did y'all know that there's usually some alerts and alarms that show up before that happens? That's what's crazy, right, about fatigue. Like, you may be breathing heavy before you have a heart attack. I don't know. That could happen, right? So there's usually some signs and symptoms before you get there. A lot of times we're not the best at paying attention to our own signs and symptoms. So a colleague, a supervisor, a friend, a peer, having someone there to support that monitoring and that empowering of your own awareness of potential fatigue and compassion fatigue, that can go a long way because you're catching things at the level of alert, not the level of complete burnout,
I'm appreciating you bringing up that point. And I want to jump back to something you said, which from my role and my experience makes the hair on the back of my neck stand up. You said stakeholders, like obligations to stakeholders. And I think one of the complexities, and I invite you to speak on this topic, is the behind the curtainness, if you will, of treatment in general. The use of intuition, the use of two people in a room, and the healing aspect that's there regardless of fidelity to an evidence-based practice. And then there's this whole other side of it with the stakeholders and utilization review and grants being funded, grants being rescinded, recoupments from insurance companies. And I think, at least speaking for myself, and maybe the same was true for you, when I first started in the world of community mental health, I had no knowledge of this stuff on the other side. I had knowledge of the progress note I was supposed to write or the 11-page DMH assessment, but there was this whole dark side to treatment that I didn't understand. And I, in reflecting back, I also see that the fact that I didn't understand it was part of the problem. Because I couldn't see how the pieces fit together because I didn't even know those pieces existed until I was part of the management team, and then I was one of those pieces. But it's like you don't appreciate all of these systems coming together and why we have productivity the way we have, why we do treatment plans. No one ever explained that to me. We didn't discuss it.
Oh my gosh, right?
And it wasn't until my internship that there was actual discussion of here's what we're going to do and why we're going to do it. But in my my post-bachelor's program, we didn't discuss it. why we were doing it. I think I had one class by one professor who happened to like treatment planning, and she talked about it, and that was it.
Right.
And your point about the hole in the system of like what we get from our education and then the application to real world, I think that's a really critical hole where people get burnt out because they're undertrained and then they're lost. And you, before we started recording, you had joked that, if you're under supported working in this kind of a pretty high risk environment, if you're going to, let's say, residential treatment or psychiatric hospitalization, let's say, people burn out and they just quit and they leave the field altogether. And the next thing you know, they're working in human resources at Target.
Right.
Can you, true story. Can you speak to that phenomenon and like the rate of turnover in comparison to clinical supervision and systems that really hold staff?
Yeah. I mean, there's probably not a 1 hour gap on earth, that we can fill in the answer to turnover in our workforce, unless we go to like a hyperbolic time chamber in Dragon Ball Z. But I will say that one big issue is exactly what you said. We're not always prepared for this administrative work. We came in here because we wanted to help people, or maybe we got into this field because we needed help. And we were trying to figure out some trash that happened to us or happened in our family or happened to someone we love. And we want that trash to make sense, in our psyche, and we want it to either look like gold or look like not as foggy, and so now we've achieved that. We've at least made it make sense. There's also the root cause myth, like, well, now I'm at the root cause, but there's still no solution. Doesn't feel better. So we're still holding on to some kind of pain. I think what happens is a lot of folks come into the field for the concept of helping, whether it's helping me, helping others, helping family, and knowing how to help. But we definitely didn't come in here to figure out how to do paperwork. You know what I mean? Like I don't know that I've met a clinical intern that would answer that question that way. Hey, why'd you come into this field? Why do you want to get this degree? So I could get really good at paperwork, so I can be an awesome chart auditor. It's like, well, no, but I think what curbs the gaps is it does help to have really good and sound training from experienced individuals. I had a great trainer on treatment assessment and treatment planning that gave me an analogy once, and he said, it was in New York. He said, well, Samson, have you ever given someone directions and, told them how to get to your house or something like that? And I'm like, yeah, I'll use MapQuest. Someone help me know if MapQuest is still a thing. Or you use, or you put it, in an app right now, or, but, so then he said, well, yeah, you got to give someone a plan. You don't just like walk them into a dark forest and say, oh, just trust me, I'll get you there, and that's like, when you hear it that way, you think, oh my gosh, how could I be doing treatment without a plan of care? And how can I make sure I'm communicating this in a way that is understood by a variety of cultural backgrounds and education levels and societal, norms? Like, can everyone understand this plan of care that I'm writing out for them or that I'm making with them, And so when he kind of helped me see it that way, just in terms of giving someone a plan for directions, it helped. It gave me value. It made me feel like, oh, I'm actually helping more effectively by being a good documenter, again, that connection had to happen for me to start buying into it. Right. I know it seems minimalistic, but I think that buy-in is really critical for folks in our field. And I don't think enough people take the time to help us connect those dots and get that buy-in when we're learning new concepts like chart auditing, treatment plan review, care plan, updates, things like that.
I agree. And I think part of what I've seen, and I'm sure you've probably seen the same thing, is that when we're looking at the required coursework for these professionals, very rarely is there any component there that focuses on documentation. And yet, if you look at the state laws or the law and ethics regulations for a particular state or entity, it'll specify that you need to keep quote unquote sound clinical documentation. But no one really says what that is. And so to me, it's always been like driving on the Autobahn, but there is actually a speed limit and no one told you what the speed limit was. And right. I think I would imagine it really contributes to burnout. And speaking for myself, when I went from my outpatient internship, well, what was it called at the time? It's like, well, I was still in school. And then when I actually started to be a therapist, after graduation, working in a large facility. I literally remember doing the whole curl up in a ball under my desk and like shake back and forth thing because I couldn't get the documentation done. Because it was just so much stress. There was so much pressure to take new clients, and we would get 8 new admits, and 2 would be mine, and their details were very similar to the other 16 that I already had. And just this freak out that occurred in that environment. And in retrospect, it actually was supervision that kept me from losing my mind altogether. So when we're looking at the benefits of supervision, you had said that it basically improves client outcomes, is what you've seen in the research, and then hopefully would reduce dropouts by clinicians themselves. Are there other benefits that we need to be talking about? Because I think one of the things I imagine that, and you've already tipped your hat to it, one of the hurdles is getting non-clinical executives to buy into the cost of supervision when it's not reimbursable.
Yeah. I mean, I'll tell you now, I'll say, for our partners on that side, of things, business partners, this is one thing I'll say is that I've seen a tremendous amount of openness when, rarely do they say, we don't have time for clinical supervision. I think that gets interpreted by those on the field because there's other goals in front of us and priorities, and we're always looking at census and numbers and this and that. And so we may, unintentionally interpret that clinical supervision is not a priority because it's not put right in front of us every week, and so I think I don't see that there's folks on the other side that are telling us directly. I've never seen it, honestly. We don't have time for clinical supervision. I've never seen it, right? So they're open to it. I think honestly, we have to own how we are crafting our environment. We are the clinicians, so people who are credentialed clinicians in a program, they've got to know when to keep clinical supervision at the forefront of a priority. And the moment it starts getting delayed and all we've had for 3 weeks is quick team meetings, quote unquote, and we're kind of writing that off as supervision. We know that ain't no supervision, right? We're doing these team meetings that are highly administrative. They're really about our operational goals. And then we dismiss and just go back to independently managing our caseloads with no idea of the highest ethical or relapse risk in our programs. That's the alarm. Like now it's like, oh, okay, we need to get back, but it's up to us to own that and to bubble it up. Now you also asked about other benefits, to kind of keep on our mind. So one is, and again, this came from the same text, Clinical Supervision in the Helping Professions, a Practical Guide. So one was retention, and retention is twofold. So consistent clinical supervision leads to improved staff retention. Now, what's funny is it's not even really about the type of supervision. It's just about whether or not it exists. Dr. Tanya Lashober did this study with the University of Georgia in 2013. It got validated again in 2016, and the study was on effective clinical supervision, ECS, and they were testing out different models. They were testing out different educational disparities between the supervisor and the counselor, all these different things that you would assume matter when we say, how do we define effective clinical supervision? What they found was all those studies on different models and different educational disparities were inconclusive. And the only thing that showed a drastic difference was consistency, whether or not supervision actually occurred as scheduled. And so they actually defined effective clinical supervision. If I could find the definition, I was trying to Google it, but essentially, it got defined as supervision that happens consistently, and oh, here it is. So they defined effective clinical supervision in this study as building a consistent, structured, and clearly defined relationship with scheduled interactions between a senior licensed or certified professional and a newly licensed or certified professional. Again, that's Dr. Tanya Lashober. The study is called Effective Clinical Supervision in Substance Use Disorder Treatment Programs and Counselor Job Performance. And it was just I think the conclusion of saying, hey, is it actually occurring is something we've got to pay attention to, because it's just about it happening. That actually will get you more bang for your buck than trying to, identify the perfect model, right? And so that's kind of, I think that's, where I want to push is it impacts retention, for our staff. It also impacts retention for patient retention, because what we've known for a long time is staff retention leads to patient retention. If Beth is my counselor, in January, and it's now June, and I'm coming in for a 6-month check-in, and Beth is still my counselor, that retention upticks greatly versus me having to meet a new person. And now it's just a little bit more of a distance of trust and familiarity with the program,
I was smiling when you were talking about that because I could hear so much overlap with the alphabet soup of evidence-based practices. And so for the therapy land, it's like connection is the primary driver. And you're saying in the effective clinical supervision space, consistency is the
Oh my
primary
God, there's
driver.
so many parallels. Yeah, there's so many parallels between the treatment alliance or therapeutic rapport, patient rapport, and supervisory alliance or supervision rapport. I mean, there's a lot of parallels between those two, and part of it is, predictability, creating a safe space, consistency, being a good listener. Like, I mean, these are really key things that are not technically these evidence-based, like you said, alphabet soup, but they are indicators of patient rapport. And this is how you see patients, being more satisfied with the care being provided to them. But we also have that on the supervision side is when the supervisor is present, accessible. They may not be an expert on TFCBT. They may not be an expert on relationship trauma repair, or something that you really want to learn and grow at as a new clinician. But what you really need from them is to be available, is to be accessible, is to actually offer some structure and some layout into how you are independently working, and also, coming in for that check-in, because both are important, right? You can't really grow in this field if you're not trying out your own decision making on your own. Sometimes you have to, right? So you need both that autonomy, and you also need your connection with your supervisor, which, by the way, is the same with our patients. They can't have the Beth app, in their pocket where it's like, oh my God, I'm dealing with a crisis, let me text Beth. Like, that's not counseling. That's something different, right? It's nice. It's pretty awesome to have that support, but you don't really get to practice your own decision making, so that autonomy element is also an interesting parallel between the two.
I'm rethinking, as you're talking about this, like rethinking my own supervision experiences in this framework, and looking back for myself, and for our listeners, I wonder if the same was true for you. My supervision at many sites was sacred space. That was what we did every Thursday at 11, and that was sacred space. And looking back on it, we were in very hot water, as I say. I mean, the kitchen got hot in residential treatment, working with gang-affiliated youth. And when things, as Samson and I were talking before the interview, when things went wrong, they went wrong very quickly. And so, of
Yep.
course, emergencies happened. But barring emergencies, it sounds like these facilities were profoundly doing something right, because that was sacred space.
Yes, without a doubt. And like you said, with emergencies, it's like they're going to come. We all adjust, apply that flexibility and bounce back, right? It's like we can't let emergencies craft our culture. If we do, then now we're pretty much saying our patients are the experts on treatment, not us, right? So there's a big difference between having emergencies and letting them design your environment of care. You can never let it go that far, where all you are is, a unit of clinical care that is responsive to crises. There's more to it than that. That's, again, like that bare base level, right? At some point you bounce back, you say, okay, we got to get this supervision back on schedule. Now, I was fortunate. I had 3 pretty polar opposite supervision experiences. One was just like you. It was this sacred space. And I would say out of a year, I could honestly tell you 3 times in a year that supervision got canceled or rescheduled. I mean, it was that consistent. And usually it was someone got sick, very last minute, or, something like that, but like 3 times. So it was very sacred, very consistent, very structured, very much of a case consultation model or case review model of clinical supervision. I also had another model that was like wild. It was the Milan systemic model of clinical supervision. So this is where you have a supervisor, a peer, or a senior colleague that is on the other side of a one-way mirror, and they are watching and listening through a microphone into your session. And that supervision is very like in the moment, on time, and you could mimic that by doing recordings, by, having an updated, privacy policy where you have someone sign off that they understand that you're receiving supervision, and you are signing to give an agreement that a clinical supervisor is going to view this for training purposes. That could be in a video recorded session or an audio recorded session. Very, very common. And in fact, I have a fully licensed clinician that is doing that, with me, and I love it. I'm like, hey, I'll sign it, keep learning, because if you're learning as my counselor, that means I'm safer as your patient, and I feel like it's a benefit as a patient because I'm looking at it through the lens of a counselor versus a counselor who has never been observed for years because they've been fully licensed, right? Versus the counselor who has no accountability. As a patient, who do I feel safer with, right? In comparison. And so I will say that Milan Systemic was a learning factory. It was incredible, the amount of pliability and flexibility I had to have as a clinician, as this supervisor could call into a session in the middle of a session with the patient, be like, no, go here. Don't go there. Ask this. And it was just really, really, a really sound kind of experience. I love it, and in that setting, we would still debrief. We would still do a group supervision where we all got to bring our cases and our notes, in group. And then I was in a third environment where supervision was, if it was structured and if it was happening, it was a miracle. I mean, like maybe once a quarter, we finally had it as scheduled, and that was stressful. It was really stressful. That supervisor was always available, that an open door policy. So there was a lot of warmth, a lot of nurturing, and we all learned from that. We definitely took something from that. But if that was all I had by itself, I don't know that I would have been able to independently succeed, at this level. I think that I would have been safe for that moment. And definitely I would have known what to do on the job because, again, that supervisor was available. There were open door. But it was chaotic. It was all over the place. I had no chance to fill out a form of my toughest cases and present it to that person and say, how do I answer this kind of stuff? Like that rarely happened,
In California, speaking for marriage and family therapist associates, so pre-licensed MFTs, the requirement is both individual supervision and group supervision when pre-licensed. What is the research between these two modalities? Is one better? If as a program we only have so much financial capital and time capital to spend, which is better bang for our buck, group or individual?
Yeah, I mean, great question. I would not go too deep into the into the weeds on like the research, because I honestly don't think we have very sound research in comparing the two, right? That's just my honest opinion, because I've looked and I've seen some things that are very anecdotal. But let's go to just logic, right? If you are an introvert and you're in group supervision, you're gonna maybe not push yourself to ask the questions you need to ask. You're going to want to have a supervisor that may approach you and say, okay, so-and-so, what about you? How are your cases doing? And they may have to be very directive. But what if you don't get a very directive supervisor and they're more open process and they're just letting people share openly in group supervision? There's a risk that you've gone month after month, week after week, year after year, dare I say, not actually getting supervision, but rather learning vicariously from other people's, which, again, it's not all or nothing. It's not that that's bad per se. You're just not getting the full bang, right? In individual supervision, someone can really, really dig deeper with your interventions, what you expected to happen with that intervention, and then what actually happened, how you can observe, the patient's reactions to your interventions differently through the lens of that supervisor. You can really go a lot deeper with your clinical skills and growing and sharpening kind of those muscles and that responsiveness between you and the patient in individual. It's just about time, if I'm baking 20 cakes, are they going to taste the same, in terms of quality and consistency as if I just baked one and really focused on, the ingredients and focused on every single element of it? Like, it's about focus and time. I think there's some logical aspects to say that, both can be beneficial. One can be risky if that's all you've gotten, if all you've gotten is individual, you've never gotten group, you don't even know how other clinicians act. In fact, your entire paradigm is based on what that supervisor has experienced and yourself. That's all you've got. So you've really limited, your capacity, right? So I mean, I would argue that, individual only is just as risky as group only. If you really, really are after becoming the best clinician you can, get any and every form of supervision, mentorship, and training you can. Get coaching from a colleague, get coaching from a specialist, get some time with a clinical supervisor, get some time in a group, attend a training, attend a conference, network, whatever you can, just be vicious about your learning, capacity, especially in those first 2 to 3 years of the profession. It's just such a great time to point yourself in the right direction.
I'm nodding along to what you're saying, and I had similar supervision experiences to you, and I had the Milan model of recordings and watching it back and going through it both in group and in individual. And I'm glad you bring up that element of it, because there are so many different kinds of supervision. And I think sometimes, just like with evidence-based practices for mental health treatment, we get so focused on a certain kind and say this is the kind we have to do, that something gets lost in translation because it becomes so complicated. We have to be so adherent that we don't maintain that consistency, which you're saying is fundamental to doing this effectively.
Yeah, I mean, even it's funny about the Milan model. Like, here's what I'll say: does a clinical supervisor have to have observed clinical interventions or counseling happen by their supervisee? No, I'm not going to say have to. For clinical supervision to be effective, can it help? Certainly. However, as a counselor, do you have to have been observed by someone as you're counseling? I would say without a doubt, yes. I could care less who that is. Draft a fidelity checklist, draft a goals checklist, draft a behavior checklist, or get one, online, and hand it to a peer, a colleague, hand it to another counselor, hand it to your supervisor, and ask them to observe your session. If you're counseling and you're fully credentialed and no one has been in that room with you while you're with patients, how do you even know what you're doing is right or effective? I don't know in any other field where supervision is supervision without observation. I don't think that's a thing anywhere else. And yet, for some reason in counseling, we've allowed it to kind of evolve into this, where supervision can occur and even be completed without observation happening, and that to me is pretty risky.
And unusual. You make a very
Yeah.
good point compared to other industries. One of the things that I've been challenged with as a clinical supervisor, and I'm sure other clinical supervisors would agree, is that fine line you're walking, particularly with new professionals, about the focus on the learning and the intervention, and then on the personal development aspect and that holding of tension between these ideas. Do you have any thoughts on that? Like, from a systems perspective, why? I mean, historically, clinical supervision seems to break down in the addiction space in particular. Is that part of the phenomenon? Because we see many people who have backgrounds in their own struggles with addiction that go into addiction treatment. Like, where's the breakdown happening to providing adequate supervision, but also addressing both of these elements, the learning, but also the personal development, which I think is probably the scariest part for most supervisors and for most organizations. It's like, oh, I don't know if we want to talk about that person's addiction when we're in clinical supervision. Like,
right. Yeah. It's hard, right? I can't remember how long ago it was, but I know, I want to say it was in 2014, Samson and Nadac did like a quick survey of the profession, and the results of that were pretty valid. Like, almost, decade after decade, we've seen this, that about 60 to 68% of credentialed professionals in addiction treatment spaces, are in these surveys, were comfortable enough to say that they themselves were also in recovery. Right. And so we know also, if you're in this field, that you're going to bump into professionals who are in recovery, and whether that's personal for them and they keep it private, or it's public knowledge in their program and they've self-disclosed that to their colleagues. I think the big question for recovery should be the question for all professional helpers is how am I maintaining my own emotional balance as I'm helping others maintain theirs? What's happening inside of me while I'm here hearing these stories that could potentially be triggering or similar to my own story, right? And that question, it's not about whether you're in recovery or not. You could have nothing to do with substance related issues and be hearing someone's challenge of grief, of loss, of how they're managing feelings of hopelessness or feelings of financial issues that deal to it, that sometimes build up anxiety or stress related responses. And you're dealing with that too, right? And so how is that triggering you, and how are you responding to those triggers? And has your maintenance plan sort of drifted as you become more and more a professional in this field, which is what happens, Sometimes if a counselor had a counselor, I'll just ask them, hey, when was the last time you spoke with that counselor? Have you done a booster session? Are they still alive? If so, can you meet with them? If not, can we get you a new one, right? Like, I mean, I think it's more about our maintenance plan, what got us to the place where we felt qualified to help others, and how do we either find that recipe and redo it 5 years in, 6 years in, 7 years in, or how do we build a new recipe or a new maintenance plan that helps us maintain stability in the field. I honestly don't think that clinical supervision for professionals in recovery differentiate that much from clinical supervision for all professionals. I think it's all about, having you monitor your triggers, your emotional stability, and what works and what helps for you, and whether or not you're doing that. I've had a supervisee that I had to say to them, when we first started supervision, you told me your sponsor was the bomb, was like the reason you're here. They were like your surrogate parent, surrogate brother, surrogate sister. Like, they filled in all these emotional gaps for you. You've been in this program for 3 years, and I haven't heard you mention your sponsor. Is there a reason for that? Are you still connected with this person? Are they still a part of your life? And I asked that because this person was having a lot of reactiveness to how they were dealing with their patients. And a patient was showing up and getting mad because they were on a hold, and in opioid treatment programs, or in medication assisted treatment programs, a hold for us is like, you need to go see your counselor before you get your dose. And so this patient is on a hold, and they're just having an outburst, like, get that hold off, why are you doing this? And obviously it's because they had repeated negative findings on their tox screening, so something isn't quite right, so they need to speak to a counselor. And so they're having an outburst, and now this counselor is reacting to that patient's reactivity and saying, we're not going to let you get back on take homes, it's just this, this kind of fight happening, right? And so when I see this with a counselor that I was supervising, I remember, having that conversation about their sponsor. Now, in that person's maintenance plan, their sponsor was really key. In another person's maintenance plan, it may be about family time. It may be about getting those workouts in. It may be about, something that was promoting their wellness, right, before they even got here, or something that got them to there. And so sometimes you just go right back to that as a maintenance plan. It's not about monitoring relapse. It's about monitoring your wellness, to be able to help others, and your safety, to be able to help others. So I hope that helps answer your question. I feel like I went too much information on that one.
I actually really appreciate your answer, because I think this is one of the elements that we don't discuss about clinical supervision, and it is that personal development piece, that wellness piece. And I think not only is that a common element that's uncomfortable for supervisors, but it can be so uncomfortable for supervisees. I remember the first time that I cried in supervision, and it was like, am I doing something wrong? Because to me, a meeting of any kind is something formal where feelings may not be involved. And I come from a corporate America based environment. So, my joke was I generally bleached my feelings before walking into a room with my folio.
Yeah.
So to switch into a different paradigm was a huge adjustment for me. And it was jarring initially, but it was also lovely, where it's like, oh, so I can talk about what's coming up for me. This is okay. But I think when we're looking at this from a forest through the trees perspective, part of the problem is that we're, as a field, not talking about this element of burnout, of compassion fatigue, of vicarious trauma, of needing some place to kind of sift through that, and that clinical supervision can help be a stopgap.
Yeah. I always say, you can only monitor so much quality through chart audits, because technically it's like hearsay, it's kind of like, I don't know, it's kind of like trying to evaluate someone's personality based on their Facebook comment history, and right. It's like, come on, like you're reading the report from someone of what they remember happening in a session. So clinical supervision is really, I think, the most powerful and authentic way to monitor quality care, because of exactly what you just said. This individual, the helper, they are actually they're actually the source of of treatment intervention to this patient. So you've got to check on them as a person, because technically they matter. If they're if they're the helper, right? They're the tool of help. So I mean, you have to check on how they're doing, and yes, I mean, building empathic skills, but also building self-awareness. I mean, I could not believe how not aware I was of my own self coming into this field. And almost every supervision session, I mean, it went back to back with tears for me. I mean, so it's not just you, Beth. I'll say, like,
Thanks,
and
Samson.
most of the tears were like, man, I can't believe what a jerk I am. Like, I can't believe that I was viewing this patient and what they were reporting through the lens of my own bias and through the lens of my own expectations of other people, right? And even the simple things of like expectations for performance or hitting goals, I held myself to a standard that I sort of translated to other patients that looked and were like me, and so anytime I was working with men, that with Black men, especially if they had immigrant parents and they had a same path of me, if they were on my caseload, my supervisor caught me time and time again where I was holding and taking ownership of their goals as if it was my goal, and I had no awareness that I was doing that I had this higher pressure that I put on them, and it wasn't even about them, it was about me. That self-awareness, sharpening that tool, me, the counselor, it could not have happened without a supervisor catching and making me aware of those instances, right? Which, by the way, that also leads to compassion fatigue and burnout. When that's why self-awareness is so key in the field, is that without clinical supervision, you really can't build your own self-awareness. Without well-monitored self-awareness, you're going to burn out quicker. It's like you're using gas, for a car that needs oil, so.
I've had the same thought, and thank you for your self-disclosure. And the element that I see too, I've been in workplaces where you would get gold stars for being overwhelmed. So when you say I was up this late working on my progress notes, or I had to stay this many hours extra, or I did this much overtime, all of that was celebrated. And it was fascinating to me because in morning meeting, it was almost like this competition of like, who's more miserable? I am. There you win. And I think that that's such a common occurrence, particularly in these publicly funded community-based programs, because there's so much adherence to productivity. And I was speaking with a professional a couple of weeks ago who does community mental health, but she said, in our program, we don't have productivity. And I'm like, what? There's no sword? What is this? Because it is, at least from my experience, such a common phenomenon, is just unbelievable overwhelm, really high caseloads, and then all the more importance put on clinical supervision to catch and correct, because of the potential for major ethical violations and boundary violations when we're in a really vulnerable and overwhelmed place.
I think in our field, it's part of the high volume issue it's not always that someone's trying to crank out another penny. Like, maybe that's someone's intention somewhere. I don't know who this person is and what dark office they're lurking in. But let's imagine that that's not the intention. If we really zoom out a little bit, we know we're in a workforce and have been in a workforce that is, it's not apples to apples. Like, there's not enough qualified individuals to provide the care that's needed for the amount of people that need it. There's way too many patients in need, and we don't have enough counselors. We don't have enough, professional helpers. We're hiring peers, and we're getting these grants for peers. And I've heard some counselors say, "Oh my God, they're doing our job for us." I mean, not really. They're working in their scope of practice. They should be leveraging their lived experience, not clinical tools they don't know. And so, I mean, part of we're hiring peers, and folks saying, well, they're taking our jobs. And I'm like, what? Is there a counselor that needs a job?
Yeah.
Tell me where they are. Like,
give me their number.
Yes, we need counselors. Like, so, we're a lot of these workforce additions, case managers, care coordinators, peers, is helping to fill the gap of care that we don't have enough folks, Now, what I will say is the management of productivity versus self-care, your ability to keep being productive, let's say year over year, it's almost impossible to manage that balance without a supervisor, without someone to be responsible for case assignments, and so that is something that I'm really proud of at BHG, at Behavioral Health Group. Like we have pretty much made it a staple where it is the clinical supervisor, which hopefully is the highest credentialed, clinical individual in the program, that's responsible for case assignment. That way it's not coming from the program director or someone who's in charge of revenue. It's coming from someone who's just responsible for clinical. And it does help us to kind of keep things in balance because, in OTP settings, not all patients are the same, right? And same thing with inpatient residential. So it's like you don't want, even in private practice, you don't want 22 patients who are borderline. You know what I'm saying? And you also, in OTPs, opioid treatment programs, you don't want 22 patients who are like a code 7, or meaning they're on dailies where they have to come in every day for their dose, right? Like that is impossible to keep up with and manage. The amount of hours in the day just doesn't add up. You'll never be able to do it. So having a supervisor kind of dice through all those details, the individual's diagnosis, their needs, how long they've been in treatment, how new they are, medication induction versus stabilization, right? Having a supervisor help space through some of that as they assign the caseload really makes a big difference from both an operational and a clinical side. Now, the other part is how we interpret productivity. And the way we are interpreting productivity is patient engagement. And so we are saying, okay, if we are looking at productivity in terms of people who are doing numbers and cents and, ratios, we want to look at it as if this patient is new, they have high needs, they have high risk, they also have some home or environment issues, right? Where there's a safety concern because of where they live or if they don't have somewhere to live, then yeah, we're going to make sure they're on the caseload of someone who has the time to help with all those resources.
The wraparound, right?
Because that one counseling hour is not going to be enough for that person. You may have to be on the phone with a social worker, financial aid representative. You may have to be on the phone with someone who's doing their environment, someone in corrections. All those hours, it's about safety. And safety and patient engagement have to be connected if we're looking at it through a clinical lens. So that's how we try to interpret it and how we try to respond back and have that dialogue with folks who are looking at productivity. And so that way it's more of an open discussion. And by the way, that's where clinical supervisors make a big difference because they have the expertise to have that dialogue, and they know how to understand both the business intention and the operational intention. And they also bring in the clinical expertise to help them better define productivity through the lens of patient engagement and patient safety.
It sounds like then if you're looking at a program that historically has not had that much of a focus on clinical supervision, part of it is shifting kind of the paradigm from a reactivity model to a responsive model, the focus on prevention and early intervention, and how do we start re-injecting resources to develop some of these nuances that might be lacking.
Yeah. Yes. Well said. Well said. And again, there's another parallel. It's like, how do we work with patients who don't have the resources they need to make the next step? You may see a patient and say, oh my God, you need to be in here weekly. There's a lot going on. I need to see you next week. But what if their payer won't cover weekly? What if they don't have enough, insurance or enough funding for weekly? What if that patient doesn't have the transportation or the time off to come in weekly? How do you adjust your solution to their needs and their preferences? It's the same thing in clinical supervision. If you're working with a program that's remote, they haven't had clinical supervision going on for years, are we going to say, hey, you have to hire a clinical supervisor by the end of the month? That may be an unmanageable goal, right? So instead, you may say, hey, let's get the seniority. How many folks do you have here who are clinicians? Who's been here the longest? Let's start with a group of peers. Let's get, let you guys review some cases, bring up your most complicated cases once every other week and bring it to this group meeting where all of you as counselors, until we can hire a supervisor, at least you all won't be alone on how you're managing this case. And you can pick through each other's experience to share something. So in other words, start somewhere. Anything is better than nothing, and you try to inch them closer to patient safety through quality monitoring and hopefully get that clinical expert in there eventually. But at the meantime, set some sort of goal,
Thank you. That was actually going to be my next question of knowing that many programs are struggling to find qualified clinical supervisors when we're trying to revamp a program and improve these things. It sounds like your advice is look from within if you can't find something from without and work with what you have in the interim to create the culture of involved and flexible clinical supervision.
Right. Beth, you remember the place we worked at? They used to have this thing called the snap,
Yes,
anytime we would train on it, I'd make
indeed.
that noise with my hand because I'm corny. But it's, the strengths, needs, abilities, and preferences. Assess your program's strengths, needs, abilities, and preferences. In other words, assess what's there. What do you currently have, right? And use and leverage what you currently have. Find a way to get that learning culture, that supervision culture growing so that you're not in this stuck place of a bunch of individual siloed practitioners working in what in most places are an integrated care setting, right? So multiple disciplines working there and no one consulting on the same cases that you're working on. I mean, it's crazy, we have to talk. We have to review our cases together. We got to review our patients together for their own safety.
You've presented a lot of boots on the ground strategies today, but also overarching concepts that I hear. And I know you well enough to know that these are your soapbox items where it's like, these are the things we need to do better as an industry, and where we're not only failing our staff, but we're failing the patients and the clients because we are so overwhelmed and under-supported ourselves. So thank you for bringing more attention to this topic. Samson, we could keep going, but for our listeners that want to learn more about you and also want to learn more about this topic of how to have integrated clinical supervision in these treatment centers, how do folks get in touch with you? How do they read what you've read?
Yeah, great question. So, I mean, the funny thing is that NADAC is a great way to read what I've read or learn some of the things I've learned. NADAC, the Association for Addiction Professionals, I was the director of training and professional development for a few years there, and a lot of the tools and resources that are specific for addiction treatment and clinical supervision and addiction treatment can be found on NADAC's website. They have a textbook on clinical supervision in the addiction treatment written by Dr. Thomas Durham. He's the protege of Dr. David Powell, who is considered the father, of clinical supervision. They have a great, series on the same topic. Now, if you're looking for like really, really practical solutions, you could find me on LinkedIn, really easily. Just search Samson Teklemariam. I think my LinkedIn handle or tag or whatever you call those things. Sorry, y'all. Old school here. I think it's Sam's Tech. So SAMSTEK. LinkedIn.com/in/Sam's Tech. But I'll also make sure Beth Clearly Clinical has that. And I would love for you just to send me a message. Let me know. I'm happy to have a chat and talk about, some of the struggles and challenges of clinical supervision, how to reprioritize it or help it bubble back up to the surface. I mean, I just want to make sure we're all on the same mission, that we know that it has to happen. If I were a clinician right now and I know that I've gone 4 or 5 years where no one has reviewed any of my cases, no one has given me advice or seen how I'm working, I would be concerned. It's so hard, to be in this field on your own. And so let's chat and find a way. I mean, there's a lot of resources, and nowadays telehealth opened up telesupervision for us. And I think it's pretty awesome when we realize that at least within our state, the credentials is pretty much the same. Someone could be 4 hours away from me in my own state, but they may have the credential I need to get clinical supervision. So there's some telesupervision models out there and platforms out there that I think really help solve this for those of us who are remote or feel kind of trapped in a more rural space, and we just don't think we have an option. That glass is shattered now, right? We have an option. Technology has given it to us,
I'm glad you bring up that element too. And that's one thing I've seen in the field is a push on more resources to connect supervisees and clinical supervisors and make it an easier, more streamlined process than just randomly cold calling somebody and hoping that they do supervision. So thank you for that element too, because I think that's part of the missing piece is the structure to hold it. And I think we're getting there. Samson, it's always wonderful to see you. Thank you for spending this time with us. And again, to our listeners, to get in touch with Samson, please visit him on LinkedIn. His last name is Teklemariam. And also check out NADAC's website, which is NAADAC, to get some more resources about how to improve your clinical supervision with your facility. Thank you for joining us, Samson.
Thanks, Beth.
You've just finished listening to another exclusive Continuing Ed podcast by Clearly Clinical. If you like what you just heard and you need Continuing Ed credits, please visit us at clearlyclinical.com to check out our 1-year membership, where you'll have access to our growing library of Continuing Ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.